Thank you very much for inviting me to participate in your conference. It was a very humble experience when I first invited by Sandy and Alan, a colleague of mine, who sent me the very difficult patients that you heard this morning. He's a neurologist, but he sees a lot of pain, people with pelvic pain. My practice is in neurogastroenterology motility, so I see patients with pelvic floor dyssynergy and chronic abdominal pain, and we share some of these challenging patients. It's a humble experience because when he invited me, I really don't know too much about EDS, and this is a good learning experience for me, and I'm very happy and excited to see how cohesive the group is, and at the same time make me feel quite humble and inadequate in the sense that I feel that this is an area of a very challenging, patient population, but also a very challenging problem when we talk about gastrointestinal manifestation. I was humbled by the neurosurgeon and the spine surgeon that they have a very objective measure. Throughout the talk, you're going to hear that many of the symptoms or the manifestation we're going to talk about, we do not really have an objective assessment. Some we do, so we're going to share some of those with you, but many of these are subjective symptom-based diagnosis, which make it quite challenging. So I'm going to share some of these challenges with you. This is my disclosure. And at the end of the sessions, I know that there is a very heterogeneous audience, some of which are patients and family. So I thought I'd give you a very basic motor function of the GI tract, kind of a basic GI function 101. From that, you can appreciate and follow the rest of the talk. And I'm going to talk to you about the spectrums of the GI dysmotility syndromes as well as the functional disorder that found in the EDS patient. And you will see that we also see that very commonly and share a lot of similarity to the general populations in the world and quite high in Canada. I'm going to describe some of these symptoms associated with disorder, and at the end, hopefully, to give you a general approach of how to manage these GI symptoms. As I said, this is a full spectrum. You heard it in many of the presentation earlier that you basically have involvement of gut from mouth to bum. So it's almost near impossible to give you the strategy from every single possible disease. So this is a very high-level summary, and at the end, hopefully to give you an approach so that you can ask the right question and who will be able to help you. GI function 101, very simple. Before I was a medical doctor, I was an engineer. So I like flows, I like algorithm, and I like things that follow logic. So gut is very simple. It's only one hose in, one hose out. There's nowhere to go. If it goes somewhere else, there's something wrong, right? So when things goes in, it has to go out. When things don't go out, there is a problem. So when things that need to move along because they need to do the job it's supposed to do. So what it's supposed to do is that I thought it was strategically planned to put my talk right after lunch, right? Because you eat the food, you need to digest it. To digest it, you need to move the right area. Once it's digested, you need to absorb it. And then and at the same time, the gut needs to secrete numerous different things. The acid from your stomach, digestive juice, and that's all put together with some fluid and a hormone, put it all together, help you to perform all these functions. And you will hear a little bit, and you can kind of envision that you need the muscle, the nerve, and everything work together in synchrony to produce this final succinct and synchronized activity. So to do that, you need motility, right? You need the thing move from the mouth to the bum. Along the way, all these things happened. And the control is through a neurohormonal system. And if you think about when the connective tissue is weak, you have the architectural matrix is being disturbed, so some of these functions can therefore be impaired. So what are the basic motor functions of the gut? We all know that, we all hear, because I learned that from the ambassador that you are very educated, so all know what peristalsis is. So that happens all in the gut. It's an organized, coordinated, propulsive contraction. But we have peristalsis when we eat, so the food kind of passes down the esophagus, but the area of the gut separated by sphincter, so for a compartment, because different compartment of your gut do different job. Esophagus do different job, stomach do different job, small intestine do different job, and colon do different job. So you have gate. So between your mouth and the esophagus, your upper esophageal sphincter. Between esophagus and stomach, you have the lower esophageal sphincter. Between the stomach and small intestine, you have a pylorus. And between the small intestine and the colon, you have the ileocecal valve. and then at the end, get out from your bum is your anus, right? So all these are little gate and door. And this coordination from one compartment to the other compartment is what the job is going to be performed for you. So at the esophagus, we have the peristalsis, you have the sphincter, called lower esophageal sphincter. So when these goes wrong, I'm going to tell you what problem you may see, and that's why some of the symptoms that you can see in some of the presenters that present to you, or maybe some of you experienced. When the food gets to your stomach, you just had a meal. You can imagine the meal that you had is a full plate with all this food, and dessert and everything, and you were thinking about eating the whole plate of meal, you don't want it to empty right away. The initial function of the stomach should not be emptying. I see patients send it to me all the time to say that my stomach is slow. My stomach is not emptying properly. I have what we call gastroparesis. But the initial functions of the stomach should be relaxation. The accommodated relaxation is allow you to be able to eat a full meal without nausea or start vomiting. So the early satiation is an accommodation reflexes we're going to talk about in a minute. And a lot of the symptoms of nausea and early satiation is not because of delayed emptying, it's because of impaired funding accommodation. Afterward, titration, emptying the food from the stomach is the emptying phase. When you get to the intestine past the pylorus, then you have different types of motor function. You don't want things to move all in one direction all the time. You want to go back and forth, but because you want the mixing component so the nutrient can be absorbed. When things is moving along in the right direction, we call it peristalsis. Mixing back and forth, we call it segmentation. And then once in a while, you have this large motor wave contract from the stomach all the way to your right colon as what we call housekeeping wave. And that would help to move the food and residual down, but it also helps to keep the bacterial load down. There are more bacteria in your gut than the whole total number of body cells. 10 times more bacteria in your gut than the total number of the cells. So your human body cell. So we outnumber by them. We have to live in synchrony. When these become imbalanced, you have a condition later on, I tell you, called bacterial overgrowth. And that would affect your ability to digest and ferment or even absorb certain nutrient that was discussed earlier, like certain vitamin and nutrient. So these kind of motor complexes, again, require the integrity of the nervous system and the motor control, the motor effector cell, which is your muscle cell, that anchored together by this connective tissue that is weakened in patients with EDS. Now, when you get to the colon, again, the colon has the propulsive contraction that moves the content along to the bum that it comes out eventually. But you don't want to go out because, for example, for now, if you're sitting here, you're very excited to hear my talk, you don't want to run to the washroom. You need to have a reservoir purpose. You need to hold it for a while. So that holding reservoir function is also a voluntary control. So all these control is what we call the motor function of gut. It's very heterogeneous, right? It's different part of the gut to different thing, but overall the schematic framework is that you need the nerve and the muscle and these fine-tune of the nervous system to work together. So the next things I'm going to want to hear that so maybe gut trivia is that I told you that we are outnumbered by bacteria, right? So that's why you have the microbiome. We talk about probiotics. So if you have questions, we can talk about that. I give you one slide on that. But another trivia is that I know the neurosurgeon, the neurologist, Ellen is not here, but this is the little brain, and this is the big brain, right? So there are more nerve cells in the enteric nervous system that live within the gut that never go out. We call it intrinsic nervous system. And that crosstalk to outside to give you the function you want. What we got a brain-gut interaction, this bidirectional trafficking give you the sensations and motor control at the end. The classic example is the adaptive accommodation reflexes in the stomach. That's why I thought I'd do that right after lunch. It's perfect so if I pick this example. So when you eat a meal, the food in your stomach is stretched the stomach to open. When the stomach's being stretched, this mechanoreceptor will be activated. When it's activated, it sends signal up to your brain. You follow the green arrow up. And then the green that go outside, we call it extrinsic nerve, but inside is the intrinsic nerves. When these signals go up to your brain, you send motor signal down and then telling the stomach that I have food in there, I have nutrients in there, it's not time to empty yet. I'm still eating, so you need to relax. This is adaptive relaxation is what we call vago-vagal reflexes because it is an ascending, descending both through what we call the vagal nerve. So it is a classic example that you require the integrity of the intrinsic nervous system, couple along your extrinsic nervous system, go to your brain, come down with the motor reflexes. as the motor and also as the sensory. The muscle cell and the stretch in your stomach wall is what activates this mechanosensory stretch receptor. So this is a classic example of how this bidirectional intrinsic, extrinsic nerve and the effector cells and the sensory cell all work together, give you the final mechanosensory output. Impairment of that will give you early satiation, nausea, or maybe even vomiting. So we talk about strategy, how to manage these, lifestyle, diet, and as such. So now we have the basic concept of the motor function or the function of the gut, motor function of the gut, and what is these nerve trafficking doing. When this goes wrong, the architectural matrix is not anchoring things together. You could speculate these things happen. Your peristalsis is weak, so that's why you hear earlier a patient may have dysphagia. Your sphincter is weak, so the gate separating the esophagus, stomach separated, so you may be more susceptible to gastroesophageal reflux disease. Now, when we go to the stomach, you have these vago-vagal extrinsic nerve or dysautonomia, that abnormality. You may have autonomic dysfunction, then therefore you have impaired accommodation reflexes, or that the motor effector is not working, you have impaired emptying at the end. When we get to the small intestine, we talk about the peristalsis, we talk about the MMC, we talk about this sweeping contractile wave to move the bacteria away from your small intestine, so because the majority are going to live in the colon to do the job it's supposed to do, to get the nutrients that you need. When this contractile wave is not moving effectively, you have what we call small intestinal bacterial overgrowth. It is not unique for Ehlers-Danlos syndrome. I see it almost very frequently in many patients who have other motor abnormality. Diabetes, typical one, connective tissue, another couple a typical example, and I see many of those patients in that area as well. And that may affect your ability to absorb certain nutrients and your ability to digest certain food or increase fermentation. Therefore, you would have bloating, particularly when you have insoluble fiber. So when you get to the colon, when this motor control is not working, that's why you hear about constipation. So you already can imagine when this is not working, you have the imbalance of many of these mechanisms or underlying pathophysiology. You can have bloating, constipation, and abdominal pain. And you heard many times this morning that irritable bowel syndrome is quite common. The first study that published on the gastrointestinal complication of EDS was actually from Dr. Baton, that from 1969. At that time, of course, we don't have as good endoscopic therapy, so he described cases on patients predominantly complicated GI bleeding and some structural abnormality, spontaneous perforations, and those cases. All the cases that he had was from England, United States, in Canada, as far as I recall, about 125 patients. The most recent one, more closer to what we see these days, is the Mayo cohort that published last year, collectively put together the 20 years of experience amongst the 378 patients that identified to have GI manifestations in the cohort of 687 patients. Majority of those patients are women, and the age of diagnosis was around 30 years of age. They use the classification that you're all very familiar with, and a majority of those, about 3/4, are the hypermobility one, and the classic vascular, and the other, and the undifferentiated one is as listed there. So this is their cohort. Majority are hypermobility, so they group all the other subgroup to non-hypermobility. So if you look at this, you already say it's a very busy schedule, but what they tell you is that it has a lot of GI symptoms. And this GI symptom, the question is it more prominent in EDS, or is it the same as Canadian or North American? Because if you look at digestive health, if you go to Canadian Digestive Health Foundation website that we write in, it's based in Mississauga, that's about 20 million Canadian. We only have 37, right? 36, 37 million Canadian. 20 million Canadians have digestive health problem. Not all functional bowel disease, but some form of digestive health. So it's a very common problem But if you look at the one that I highlight for you, that you see the nausea, vomiting, reflux-like symptoms, abdominal pain, IBS-like symptoms, constipation and diarrhea are the more prevalent in this patient population compared to some of the other symptoms that listed in the cohort. Amongst the hypermobility subtype compared to non-hypermobility subtype, constipation and IBS are significantly different from the rest of the group. The question I had was, is it more prevalent in this group compared to the general population? So the only extrapolation I have is I then transfer to the patient, the population prevalence study. So this is the world map of IBS that you can see. Canada is I'm not very sensitive on color. Is that purple? So the purple one is there somewhere around that you said about 15 to 19%. The most common statistic is about 1 in 7 Canadians have IBS. In the States, it's a little bit lower. In the States, it goes down to about 5 to 10%. If you look at the IBS population, that in the last one is about 30%. So it does look like that. This is an American cohort. So if I use American data, it is about 3 times more prevalent in the EDS patient population. It's not too surprising when we talk about because the effector and the contractile matrix is weak. And if we look at the even extrapolated Canadian cohort, we're still at least 2 times more common. So it is more common, and we kind of have a pathophysiological basis and think about why it is, although it's never directly being studied. It is more like an associated observational hypothesis. Knowing those are the common symptoms, they also look at what are the most common medication used, and it's not too surprising the medication they use were the medication used to treat those symptoms you talk about. PPI that was talked about earlier, that will be for the reflux disease. You have drug for vomiting that I would assume they put it all together for the gastroparetic type symptom, the nausea, vomiting subgroup. The drug for the constipation, they probably group it together with the IBS-like. And the opioid analgesic is because for pain, but opioid also would have a lot of GI side effects. So I thought I'm going to share with you a very high-level summary of different class of medication in my practice, in my opinion, learning from other functional bowel disease patients, not on EDS patients. There's no study I find specifically looking at EDS patients on these particular study or trial. But extrapolating from what I know how to manage functional bowel disease, I'm going to share with you some of the experience, how I think this medication could be used in an optimal fashion. So many of you may take PPI. PPI is a very effective medication I'm going to tell you about, but PPI is usually asked to be taken roughly 15 to 30 minutes before meal. The reason is that you have these pumps sitting inside the parietal cell where it makes the acid. When you eat, it activates these pumps. These pumps go on the surface of the parietal cell. You have the drugs around, you block the pump, and then irreversibly block. So this pump, once it's blocked, you need a new pump to regenerate before it works. So it's effective, but you have to couple along the expect caloric delivery. But if you think about that, I have slow stomach emptying, I may not be able to eat my meal, it may not be as effectively delivering the medication. So if you using it effectively, it is a very good medication. It binds the proton pump irreversibly until new pumps being made, but it only works on activated pump. That's why you take it half an hour before meal. These are all the examples, you see all of them. For the simple mind of doctor, they all end with Prezol. So we all know these are PPI. Some of the newer agent is slightly different from the others. I just share with you my personal experience of a new medication that is exactly the same drug. It just delivered in a slightly different fashion by understanding the physiology of the gut. The stomach makes acid, pH is 2 in your stomach. And as the gut go down, the alkaline, the acidity go down. So the pH go up, so go closer to more and more 7 or neutral. So this drug is delivered in such a way that it activates by pH. So you have a more sustained release lasting for longer. So one of the trademark that we are now able to use this medication is that you do not have to take it 15 minutes or 30 minutes before the meal. I find in some patients who have difficulty control the reflux symptom, when I switch to the more sustained delay release, a more sustained extended release, it would allow the able to control those symptoms, particularly my patient with motility disorder like scleroderma or diabetes, patient who have autonomic neuropathy associated with diabetes, or my post-lung transplant patient. So one thing to think about is to use different medication, not all PPI the same, and not all PPI metabolize the same. They use the liver enzyme differently. There has been study looking at one PPI, and then patients switch to another PPI, and 1/3 of those do better. You don't have to use the newer one. The only challenge when I use dexlansoprazole is that it's not covered by ODB, that you need to have a private drug plans to pay for that. These are some of the common side effects. I just add that slide when I was listening to the lectures earlier about the nutrients, so I thought I should put it in. So it is known and documented in high dose long-term use. There is some association of iron and calcium absorptions and also B12. So for my patient who are on twice a day dose or high dose for long-term, I do check the vitamin B12. The iron absorption is because that you need the stomach acid to keep your iron in an absorbable oxidative state in the small intestine so that it will be absorbed. The calcium, it's generally would be okay if it's dietary calcium. If you take calcium supplement, it's better to take it away from the time you take PPI, but it also opposite the time because it's a once a day dosing, or take calcium citrate. Don't take calcium carbonate because it need to release with the stomach acid. So those are a few things you can get around. But if we look at some of the clinical outcome measure, osteoporosis, hip fracture, it's a public domain. You can go to Canadian Associate Gastroenterology. We have positional statement that is mostly association, at least at this current time. It is not all causality because most of the patients on PPI have the risk factor for some of these complications, except one patient population, which if the patient have cirrhosis, they are at increased risk for ulcerative colitis. But it's not generally applicable to this patient population. So after PPI, I want to go in the more vomit. This is the vomiting, the nausea, the nausea and vomiting component. That is a little bit more challenging and complex. So just stay with me. So how do we feel nausea, right? So there's something called a chemoreceptor trigger zone. It's a very tricky, funny area that in your brain stem that sample outside what it's in your peripheral blood. It's called chemoreceptor trigger zone because it samples what it is in your blood circulation. That's why when you give toxin that's circulating in your circulation, in your blood, it's sample and then signal and then cross and go to the vomiting center, vomit it out. It's not right for you, right? So that's why when patients get chemotherapy, they get nausea. Or that you get sick, you get toxin or gastroenteritis, you vomit. So it's triggered by the chemoreceptor trigger zone. And the signal that comes up, if you see the bottom box, up is the vagal afferent, and that is a 5-HT3 receptor. So we use an agonist, and that's why in those patients that ondansetron type medication work very well. I show you this picture is that you have a schematic framework. When I manage this patient, I use multiple mechanism of blocking the nauseating center and avoid vomiting. But at the same time, I think about where the nauseating signal is going into the brain and giving these obnoxious stimuli. So if it's coming from the stomach up, from the vagal afferent, something in your gut that is not working, the 5-HT3 receptor is a good option. If it's something from the toxin, side effect of medications, or that's some toxin in the blood circulation, again in the chemoreceptor trigger zone work well. The other receptor in the same zone is called a D2 receptor that we talk about later. It cross-mix, it's domperidone, many of you may have tried before. It is an anti-nausea medication, we call it Antiemetic, but it's also a prokinetic, work on a slightly different mechanism, but it works as an anti-nausea mechanism through your chemoreceptor trigger zone. But if you're thinking about the nauseating signal is because of inflammation or irritation in your stomach, it is not going to work very well, right? So some of the others that I would use it sometime, although it is not directly from the gut or chemoreceptor trigger zone, it comes from a vestibular system or directly in your vomiting center, is the anticholinergic. Anticholinergic, the one that I sometimes use is called polyamine patch, that's to break those vomiting cycle if they can afford it, and then Grapho against it works centrally. So this is my schematic framework. I separate symptom management to motor management separately. When I talk about the prokinetic, you would know why. Because many of the prokinetic that I give to people make them more nauseous. It's the most common side effect. So they don't concur. We know that from the Gastroparesis Consortium from NIH, we spent millions of dollars looking at this. They do not concur. At the most, you get 1/3 concordance. When you improve stomach emptying, you improve nausea. So we have to think about managing these symptoms separately. When I pick antiemetic, you saw 80% or more of these patients are women. Many of those are childbearing age. My choice will be diclectin. It's a very good antiemetic. It is very safe for your pregnancy. We give it for first trimester hyperemesis. So I use it as my background. They can use it twice a day, 1 to 2 tablets twice a day. Start with evening dose, delay onset. They wake up better. They have no nausea in the morning. They get out better throughout the day. And it works on your histamine receptor. So it also have a vitamin B6 in there to potentiate its effect. So I use diclectin as my backbone, and then I use the other medications back and forth, depending whether it is acute or chronic use. So common patch, I talk about it, but it will be private coverage. If they have pain predominance, then sometimes I think about tricyclic. We talk about the nerve, right? The nerve-gut interaction. If you think about the serotonin that's circulating in your blood, we think about all these stress neurotransmitter, make people stressed, make people anxious. 90 to 92% of the circulating serotonin is produced by your gut nerve cell, not from your brain. So if you can imagine later when we talk about IBS, that's why CBT relaxations and all those or stress can potential one way or the other to affect how you perceive these symptoms is completely because of what we call the brain-gut interaction. So I use TCA if a pain predominant, but it has anticholinergic side effect. It generally slows down the gut. So what I then do is that I will use SSRI. It's a neurotrophic modulator. It decreases pain and it also treats anxiety, but the nerve there is the same as the nerve here, which we talk about. It's not that I don't believe my patient or think that they are crazy, but I do think that it is bothering them. It is originating from a nerve perception. So I would use SSRI and SNRI. One of the medication I use is mirtazapine. It does 3 things. It helps you to sleep better. It decreases noxious stimuli, so it improves functional dyspepsia, but it also appetite stimulating. Particularly those who have poor appetite and weight loss, it's 3 birds with 1 stone. So I use mirtazapine. My starting dose is 15 milligram pure QHS. If they can tolerate it, I may go up a little bit more. I talk about funding accommodation. Right? There's only one drug that we know that works in the patient with functional dyspepsia, not again in this patient population, is buspirone. Buspirone works on the 5-HT1A receptor as an agonist, so it relaxes the stomach. So if they have postprandial nausea or early satiation, I generally would start with 10 milligram half an hour AC meal. That would enhance the funding accommodation, decrease postprandial nausea, so they feel a little bit better. It's about symptom control and quality of life, but it does not improve motor function. Now, motor function. So motor function, we talk about prokinetic. Prokinetic is a group of medication that enhance peristaltic contraction of the gut. There are a group of these medications that you see on the right-hand side of the slide. Metoclopramide and domperidone, you can think about that it works similarly. Although Health Canada put out that there is a cardiovascular potential side effect with domperidone and high dose use, but if you watch out the electrolyte, you look at the QTC, I use it very safely on 10 milligram half an hour AC meal, even up to 20 milligram QID in some of those patients that require. Metoclopramide and domperidone work very similarly. I still prefer domperidone as a baseline medication because metoclopramide cross the blood-brain barrier, give you the extrapyramidal side effect, and about maybe up to 5% of patients chronic use 3 times more likely in women than men would develop tardive dyskinesia. When they develop tardive dyskinesia, even if stop the medication, small number of patients do not reverse the motor dysfunction. So I use metoclopramide as a PRN dose and try to avoid if I don't have to in women. But if that's the only medication work, as long as the patient understands, we will go ahead. So my background is domperidone. If I have to, I use metoclopramide. They work in a similar fashion. Erythromycin is very, very good prokinetic. I told you about MMC, the migrating motor complex, right? That is sweep, the housekeeping way that sweep all the way from your stomach to the right colon. We studied this in diabetic gastroparesis. It worked very well. But what's the most common side effect of erythromycin? It is nausea. So again, separating the motor control and symptom control. Otherwise, you'll be confused, your doctor will be confused. So this, I use it as a prokinetic if I really need to empty things away from your stomach. It works on the motilin receptor, stimulate that migrating motor complex I told you about in the regulatory motor control of the gut. But it developed tachyphylaxis, meaning that if you use the drug for a long period of time, usually for 2 weeks or more, it may develop tolerance. So the way to deal with it is to use lower dose if your doctor wants to use it in a chronic use, or that you give yourself a drug holiday about 5 to 7 days, restart again, it works. So this is erythromycin as a prokinetic. As a prokinetic drug nowadays, the only one we have is prucalopride. It is a 5-HT4 receptor. In the past, for those who has been around for a bit longer, would have heard of cisopride and tegasterol. They are not available right now because of the cardiovascular side effect. Prucalopride has no documented cardiovascular side effect. It is a good prokinetic, but it's also a full 5-HT4 agonist. So it only works as a motor control. The most common side effect, about 1 in 5 to 1 in 7 patients on prucalopride would have nausea. So nausea, abdominal pain, headache, and diarrhea are the common side effects. Generally, it will be quite tolerated. Usually that we can use it up to 5, it will usually get better after 5 to 7 days, but watch out for those symptoms. So now let's go to constipation. We talk about prucalopride is one of the medications that we use it for constipation. Opioid, I give you one slide that just on one of the new medications that now indicated in Canada, once a day oral dosing that we can use treat opioid-induced constipation. So you talk about IBS, right? We keep talking about IBS. Now we talk about constipation drug. They are very similar. It's a spectrum of disease. The only thing that separates is the abdominal pain. You saw that on the earlier table that the Mayo cohort, about 50% of these patients complain of abdominal pain. It goes back and forth. So when I pick an agent of choice to treat this patient, I try to choose those that work on pain and also work on constipation. We talk about IBS already. You already have the concept. It is not just a motor abnormality, but it's also a sensory abnormality. And the sensory modulations could be changed or modulated by stress, by the microminute, by the bacterial overgrowth, by the infections, inflammations, or what we call visceral hypersensitivity in those patients that have chronic stress. And these go back to the brain. We will call the brain-gut interaction. It keeps modulating on its own. So when we think about treating patients with irritable bowel syndrome, we can deal with the motor control with pharmacological agent. We can watch the diet to decrease those that decrease gas fermentation, but relaxation, meditation, lifestyle, and cognitive behavioral therapy also have a very strong role in managing this patient to have a satisfactory outcome. When we talk about chronic constipation, many of you already know this medication. Fiber supplementation, PEG 3350, if it's over the counter, or Bilaxidase or Restorelax, they all have strong recommendation. Lactulol, they are considered as an osmotic laxative. And then you have Prucalopride, we talk about is a prokinetic. And in Canada now, we have liniclotide, is a secretagogue. So it's draw fluid in via the chloride channel in the gut to improve stool consistency and improve constipation. So dealing with the motor component or the constipation symptoms is easy. But when we now overlap it with pain, in those that we classify with IBS, it becomes more challenging. So when we look at those who have pain predominant, the only two medications that recommend strongly based on the recommendations that through the great evaluations is liniclotide and lubiprostone. In Canada, we only have liniclotide, and the dosage is 290 micrograms once a day, and the number needed to treat is about 6, meaning that in the clinical trial, I treat about 6 patients, one of those will gain benefit. So this is an algorithm that we put together to help family physician and general practitioner how to manage the spectrum of symptoms. We start with lifestyle and diet modification. We want to identify those patients who have red flag. If they have red flag on the right, in the purple box, that we need to send to a specialist, meaning that you have pain that wake up in the middle of the night, you have weight loss, you have anemia, you have visible blood, and you have a family history of bowel cancer, that with the right age that require investigation. If you have alarm symptom, alarm feature, you refer to specialists. If it's not, we try to subtype them. In this particular management algorithm, it's no different from what we talk about, that if you don't have enough fiber, again, diet and activity, lifestyle and diet modification is important. So the first strategy will be fiber supplementation. The general fiber supplementation is soluble fiber that would help to give you the bulk. Again, we don't create stool. Stool is residual of what we have in the lumen from the digestion and the turnover of the epithelial cell, the lining of the gut. So you need the fiber to create that transit to have the stool bulk. And then if the transit is not going adequately or slow in the way, then we would increase the weight by giving osmotic laxative and or prokinetic, and I have some options there. And if they have pain predominant, then we will use liniclotide because of the recommendation that it also helps to improve pain. If it's have more pain than what we can deal with without causing the side effect, then we give neurotrophic modulator like tricyclic antidepressant or SSRI. We all talk about diet. I saw that even in your menu, in your registration, have a gluten-free diet. So we talk about the 10 times more bacteria in the gut. We as a human do not have enzyme to digest fiber. We're not cow, we're not rabbit. We don't have cellulase, right? So the bacteria digest the fiber through a process of fermentation. It makes gas. It converts to short-chain fatty acid we absorb as an essential nutrient. It also produces a number of different nutrients. So when this indigestible content gets to the gut, it digests, ferment. If you have more bacteria, you have more gas. If you have visceral hypersensitivity, your gut is very sensitive, you're going to feel more than other people who don't feel it. So avoiding certain food gas fermenting or producing food would help to decrease bloating and decrease symptoms. And one of the more studied diet is the FODMAP diet that you may have heard about, that essentially are the food that tend to make gas. So for patients who have bloating and general abdominal discomfort, it works quite well. It is not an easy diet, so you need a dietitian, but there is an app that can help you. For those interested, I can show you the app after. It's very easy to use. It's developed by Australia. But in general, there's another trial look at what we call IBS diet and low FODMAP diet. In general, the IBS diet is frequent small meal, don't wait until too hungry before you eat, low fat, not too much insoluble fiber, works similarly well. So it may be, it's not, the verdict is not out, but if you want to eliminate everything that tend to make gas, low FODMAP is a very good option. And then you reintroduce the diet every 2 weeks with the guidance by dietitians, or that you educate yourself by looking at the app. We talk about the bacteria. We also talk about, you would hear, you go to your health food store, you all hear probiotic. Currently, there's some signals suggest that probiotic help to improve abdominal discomfort and improve quality of life in patients with irritable bowel syndrome, but it does not specifically improve pain, and we don't really know exactly which probiotic or which dosage. So if you, there's no one clear recommendation, but if you want to talk about some personal experience, I would like to talk to you afterward. Opioid-induced constipation. The only one that I use in my practice now that it's become available is naloxone. It's 25 milligram once a day. It's a pegylated peripheral mu opioid receptor antagonist. So it does not it doesn't cross the blood-brain barrier. So it does not have take away the analgesic effect, but it take away the opioid-induced slow gut issue. So again, it's only currently covered by a private drug plan. In the States, they have lubiprostone, but in Canada, we only have Nonoxagol. The trade name is Movantik. I generally would treat it with the same management strategy as my slow transit constipation patient, but if they are not able to tolerate or not responsive, this will be a good option as a second-line therapy. In summary, I hope that I don't think I need to convince you. You already know that GI motility and functional symptoms are quite common in patients with EDS. Amongst those symptoms, the symptoms associated with gastroesophageal reflux disease, gastroparesis-like symptom, constipation, and IBS are the more common symptoms that these patients experience. I think that it is important to think about that we need to design, when we treat this patient, you need to think about tailoring a therapy regimen for that particular individual patient and see how they respond and modify. I tell all my patients that what works for you may not work for my next patient, and what worked for my last patient may not work for you. So we have to get to learn and know each other, and we slowly reiterate a few times, eventually get to a regimen. Most of these can be managed by general practitioner or family physicians, but the time that you really need to think about our help is that when these trial and attempt and reiteration is not working as you expect what you know the drug works for, then you need objective testing. We, unlike the spine surgeon or neurosurgeon, we don't have very good objective testing, but we do have good objective motor assessment of the esophagus, reflux management assessment, stomach emptying, and also colon anal rectal manometries. Those are the physiological testing we can help you to tease out when your patient particular reflux-like symptom is not responding accordingly, or that you worry about underlying mucosal disease that causing the underlying symptom, the patient require endoscopy. In terms of therapy, I think that patient education and patient engagement is the key. We need to, almost all my patients, I shift the locum of control back to them. I always tell them I'm only the coach and they have to decide what they want, because if they agree and decide this is what worked for them, generally it works a little bit better. I always encourage lifestyle and dietary modification as my first step, and take away the offending agent if it's possible. And then I slowly introduce other pharmacotherapy. We need to educate our patient and also ourselves to remember whether we want to control symptom or versus motor. For prokinetic, I already summarized it for you. Usually I use drug that target multiple mechanisms. I would maybe give drug holiday if I think that is tachyphylaxis. Do aware of the drug-to-drug interaction with cardiotoxicity. For visceral modulations, I use TCA and SSRI. SNRI, I tend to use metrazepam because of those advantageous side effect of weight gain and appetite stimulating, that it was in that category, but it worked for me, for my patient who don't want to eat. And optimizing management and think of the gut as a continuum. So if you think about that, a patient's constipated thinks it's backing up in the bum, and then they are going to get more likely to get nauseous, they get more bloated, they are unable to eat very well, and may exacerbate the reflux symptom. So even though you're treating the foregut symptom, you also don't forget about the high end. So I always try to optimize the whole GI function as a whole to optimize the management satisfaction at the end. Thank you.